Now, you may not be surprised to know that the most popular question is this: are popular veterinary TV shows increasing our clients' expectations that anything is possible? And how do we manage client expectations?
Not evidence-based, but yes.
Angela?
I mean, I think we see a very big comparison in medical programming. So my bugbear is seeing patients who suddenly cardiac arrest and then they are resuscitated straight away and come up well as they were prior to, which in reality doesn't happen. So I suppose I'm not privy to know all the veterinary conversations, but I imagine that the kind of popular press and veterinary programs encourage patients to, patients and their pets to consider that having these treatments is necessary and essential, whatever the cost. And I know we've talked about in the preparation of this session, but I think probably having pet insurance may warrant pet owners to feel that there is limitless amounts of money to pay for these treatments. I think in human medicine we are privileged to have the NHS, which provides for our care, and there is a limited amount of money that can be provided, but there's still a debate in human medicine about whether medical insurance for adults can alter or change kind of what treatments patients have. So I don't know if that answers the question.
Can I add to that? I think that actual informed owner consent comes into it, and I'm emphasising the informed bit. I made the point, and I say it again, that I don't think the average owner really understands what their pet is going through when it's undergoing some of this exotic treatment that takes time in the clinic. It all looks, and people are caring, I don't deny that at all, but not understanding that the animal doesn't understand why it's in this cage with all these tubes, and people are being lovely to it, but it still isn't much fun for that dog. And I don't think that the average owner really understands that. It's only one of the arguments, and I appreciate it's jolly difficult to handle such expectations, but I think that's one of them that really doesn't get across.
Anybody in the audience want to comment?
Sorry, Hazel Bentle. I think it's the case that we actually have a very small evidence base for many things that we carry out frequently. And so when we're asking owners for their informed consent, we're giving them rather a limited amount of information on which to base their decision. And really for the amount of time that people have been gathering evidence, it's really very sad that, for example, even routine things like neutering, we have a very small amount of evidence that we're able to give them, tends to come from our personal belief system, which isn't really fully informed consent.
Thank you. Anybody else?
Hi, Adele Waters, Vet Record. I think Supervet's now on series 12 or 13. Why do you think it's taken so long for vets to talk about this?
Because they don't want to upset the apple cart.
Yeah.
Because we're not brave enough to say, I think this is going too far. It's also something that's crept up on us. It hasn't suddenly occurred that people started doing, some sort of exotic surgery years ago, but it has crept up on us. And I think with the growth of social media, crowdfunding, things going viral, it's escalated. So I don't think we're entirely to blame for having not noticed it, but we probably do need to do something about it now.
Do you think it's partly the lack of a system? I mean, clearly in the NHS there are systems for dealing with these things, but because we're lots of little independent practices, we work in a very different way. And do you think we should be developing these systems, Polly?
I think the straight answer to that is yes, I think we should. I think we've got a hole between regular clinical treatment and a true clinical trial, which is a scientific study which is designed and so forth. And then on the other side, we've got ASPA. We've got these ones in the middle, which are an individual case where somebody comes up with some wonderful treatment that might work. And we don't have any sensible system at the moment of deciding whether it's ethical to do it, whether it's going to benefit the animal. Hence the attempt with the veterinary ethics tool to try and make people go down a system. But I do think that it's something that needs to come from the Royal College, that we need to do something about how to deal with technical innovation for the individual patient.
Okay, somebody right at the back.
Just to comment on the NHS. Obviously, as we progress all the things that we can do and all the newer advances and the opportunity to prolong life and treat people, and the expense goes up and up, eventually we're going to have to address the situation that we're not going to have enough economic activity to pay for the things that could be delivered. And I'm interested in where you think that's going to end up in terms of who and how these decisions are going to be made about how far do we take this thing, if you know what I mean.
I mean, I think this will be an ongoing debate. I think there's already rationing that happens. Whether we like to know it or not, different clinical commissioning groups will decide whether they want to pay for treatments in their area or not. But I think certainly the development of science is a good thing. Development of research for new treatments that prolong life is a good thing. Not at the expense of quality of life, I would argue, is not a great thing. But I think it's often down to what is topical, what is popular, and what will pharmaceutical companies pay for to develop, particularly in drug manufacture. And I think at some point things may change, and we may need to change it into more of an insurance-based system. But I don't think we'll ever get there quite yet. I think it's a political football, and I think the NHS is a religious institution in this country, and to do away with it would be pretty challenging. But I think there is rationing, and there will be ongoing rationing, and there will be less money available for some treatments that people would want to have, I think, at some point.
Somebody down here. Oh, go on.
Sorry, Sean Wensley, PDSA. I think AWF has given a really valuable outlet for what feels like a zeitgeist of some concern about overtreatment in the profession. Polly mentioned some voluntary guidelines from the British College of Veterinary Specialists and, of course, the veterinary ethics tool that she's worked on. But I think you just hinted at this. I just wondered whether you felt it was likely or desirable that ultimately our regulator will have to strengthen and clarify guidance in this area.
Yes, I think that the RCVS needs to make clearer what should be done about what I'm sort of calling the middle road, the individual case that needs some sort of treatment, and something exotic could be done. But at the moment, there is you don't know whether it really falls under the Veterinary Surgeons Act. It can't really be ASPA because it's an individual case and it's not an actual study. So there's this sort of terribly grey area, and I do think that it would be perfectly possible to come up with some clearer guidelines about what to do with those middle ones.
Okay, last word on this one.
Thanks. Amanda Bogar, CVS President. So, perfect time for me to say that the regulator is taking this very seriously. There has been some progress made with the ethical review panel, which I was delighted Council made permanent earlier this year, and the new members were announced yesterday. And we've currently got a very active working group looking at that interface between the ethical review panel and recognised veterinary practice subcommittee. We had our kick-off meeting, I think it was a couple of months ago, and there's another meeting later this month with exactly that aim of looking at how we can, looking at exactly that interface, and particularly the fact that some of those decisions can be very time sensitive when real patients are involved, and trying to find a better structure to help deal with that. So it is something we take seriously.
Good.
Okay, let's move on to another Slido question then. Ethical review takes time. What about the cases where rapid action is needed to potentially save an animal's life?
a subject dear to my heart. I'm the most impatient person, and I have been waiting for answers from ethical review all over the place. But it is perfectly possible to have a group of people associated with a practice where, even if it comes in the middle of the night, there can be a quorum contacted. And I'm not talking completely off the top of my head. The Vienna Vet School equine clinic has such a group. So when there's a case that is a bit dubious whether it should be treated or not, people are contacted there and then, and they will come up with a decision. And it's the sort of group of people that has an advocate for the animal, it's got the clinician, it's got the owner, it's got somebody else on the clinical team. And they can make a decision there and then about whether the treatment should go ahead, or whether it goes ahead, but you've got very clear stopping points, and if it goes pear-shaped, you stop now. So it is perfectly possible. And on a slightly longer point, you can actually have a group within a practice, and it can be a very small practice, that you can have a group of people who, when you've got a difficult one, you get them together and you say, what do we do about this case? So those are for the instant ones. And then when you start getting to a proper clinical trial, that isn't going to be instant, and it can be done through traditional methods. And now the RCVS has its own ethical review panel. It is all perfectly possible.
Angela, what happens in...
Yeah, so I suppose the priority in human medicine is to save life. So if you were with a patient who was potentially dying and there was a treatment that was available that had some proven efficacy, then you would go ahead with it. There is clinical ethical review panels that convene in hospitals, probably not as quickly as it sounds like that happens overnight, but there is clinical ethical review panels that can convene. And I suppose there are clinical trials that are in place for such occasions to be ready to treat patients with an experimental treatment should the emergency arise. So, and routinely, actually, in human medicine, we use medicines that are off license. So, to our license for a different indication, but there are some case studies or case reports that would be beneficial in that patient's case. And I think if you were using it and the focus was on preservation of life, then I think you couldn't be called up about it, really. But as Polly says, I think even if it's not a formal clinical ethics review committee, having a multidisciplinary approach is always appropriate. So another colleague on site, a learned expert somewhere else, trying to convene people and say, what would you do in this situation? But preservation of life comes first in human medicine. So yeah, I think, yeah.
Somebody over here.
Daniela, AWF and BVA. Just going on from that, what about the practicalities of, say, being a first opinion vet on the ground and you have this ethics review panel, but the owner doesn't agree with your suggestion? How do we manage that? How do we communicate that actually we're looking out for the best interests? Because these owners will often be quite upset, particularly in those situations where you need a rapid response.
Can I just tie that in with a couple of Slido questions as well? And that is how you progress when an owner is keen to do something which actually ethically you think is not right and is against your advice. So perhaps we can put those two together, and also where nurses fit into this picture.
I would be absolutely the first to recognise this problem. I think it comes back to a little bit what society is expecting and what we're teaching our vet students too, that it's not going to happen overnight, but we've got to accept that euthanasia is one of the treatments, and it seems that it is coming across, and I see it in veterinary students and residents and intern level particularly, that they're being told you can't tell an owner it's got to have its animal put down. Well, yeah, we can, because surely that is, we are the people who can actually say that. And I think it's by pointing out properly what those treatment options are, and that, yes, we can do that exotic piece of surgery, but the dog is going to hurt. We'll do our best that it doesn't hurt, but it probably is going to hurt. It's not going to enjoy life in the kennel. It's going to feel grotty. it's also going to be difficult to look after afterwards. I don't think that we are really giving the owner the option to understand what is involved. They see the power and glory on TV and on Facebook and so forth, but they don't see the owner struggling with the dog that is miserable, it's wet its bed and it doesn't like it. It doesn't like the pills. It didn't like it when it was in the clinic. I don't think that we get that across properly to the owner. So I would say we've just got to keep pushing at that one.
Okay, I think that's a good place to finish this discussion. You can carry it on over coffee, which is next. So coffee's back in the Great Hall. Could you please be back for 11:15 for the next session? Thank you. Before you go, just thank both our speakers for excellent.